can see my screen, although now that I think about it, I did not share. Hang on. I'll just share my screen. Okay. Can I just get confirmation from people online that you can see my screen?
We can see the presenter view. We can't, so we can see your notes and everything.
Oh, that's all right. There's probably nothing in there. If there is, that's just a copy paste. So that will be fine. I have no idea how to make that not show presenter view.
That's better.
All right, perfect. Well, let's kick off then. Okay, so Patient Summary FHIR IG call. This is taking part on the Trans-Tasman Symposium Day. We've had a couple of calls earlier in the morning, so the firework group call and also the AU Core TDG main call. And now we're on to patient summary. So this is a hybrid meeting and there are a number of things we're going to go through. I'd like to start with an acknowledgement of country and that we acknowledge the traditional custodians of the lands on which we all gather today, and that we pay our respects to elders past, present and emerging, and extend our respects to all Aboriginal and Torres Strait Islander people. And we acknowledge the First Peoples as the first scientists, educators and healers. Today we are taking photos and videos, both of the people online and the people present. There are some vox pops going on in the background. If you've walked past people, you may actually be video bombing their vox pops. If you're not happy with being present in either the photographs or videos, please talk to HL7 staff. If you're not sure who Emma is, you can talk to me and I will connect you with Emma to make sure that you're not actually in any videos or photographs if you're not comfortable doing so. Please be aware that this meeting is recorded, as are all the HL7 standards meetings, and this is then made available on YouTube as part of our standards process. So, hybrid meeting. Today we've got both an in-room experience happening and also online. As much as possible, we want this to be one room. So what we're asking people to do is, whether you're in person or online, if you want to participate, put your hand up. If you're in room, that means physically raise your hand. Please don't use the Teams functionality. Actually put your hand up. But if you're online, again, don't use your physical capability. Use Teams so that we can see you. We do have people monitoring that. We will be looking at that, and the chair, who's me or other facilitator of the session, will look at who's first and call out your name to make sure that we're actually looking at whether you want to ask a question or whether you want to participate or provide a comment. We're going to be doing some Menti, as we do in all our hybrid calls. And we've got a Menti code there. Get either your laptops ready, get your phones ready. There'll be a QR up soon, and that's how we're going to go forwards with making some decisions. Because this is a fortnightly call, we're going to make at least one, which is about approval of the last minutes. But there's also a couple more that's coming up in this session that we're hoping to get through. Now, I'll ask when speaking if you can say your name. FYI, I'm Danielle Tavares-Rickson. I am the fire lead for Sparked. And whether you're in the room or online, please say your name when speaking, especially when you're in the room, because you aren't logged in. There's not this helpful sort of off-mute icon saying who you are when you're talking, so that people know who you are and what you're representing when you're saying things. For those online, we're not monitoring the chat. if you have questions, if there are comments you want to make about the participation, please pop your hand up so that you can add into the experience, because the people in the room won't actually see what it is that you're typing in the chat. So moving on from that is decision making. And decision making, I'll just quickly flick back to that. HL7AU, same business. We've been doing it all morning. We've been doing it for months/years. Is that when we make decisions, we want to be really clear on what is the decision, which is the formal motion. Whether it's something simple like, how about we meet next Friday at 10 a.m.? Whether it's actually something that's quite complex. We need the formal motion to be in wording. We want to go, who's motioning? We have a seconder, and then we go through and do a majority vote through a mixture of both the in-person and who's online. That's how we progress. And in fact, we're going to do a practice run right now. So get your phones, get your laptops. Let's do it. I can't vote, but everybody else should be. And I'm about to take a tally of everybody in the room and online, and we will not move forwards until everybody has voted. So I'm about to go to the online poll for this one, which I think is you, Shelley. Did you want to share your screen instead?
Can everyone see that one?
Yes. So we've got 13 people have voted. That's not enough. There are 10 people in the room who can vote, and there is at least 4 people online who can vote. We've got 14. How many people can vote online? How many people are actually logged in? Yeah, quite a few. So I'm just going to, Shelley, can you please pop up and put the QR code on the screen? Because we've got 10 people in the room and there's quite a few more people online who are able to vote.
Yeah, sure. 2 seconds.
So go back to the Menti itself.
Yep.
And if you scroll to the bottom, see where there's the, yeah, perfect. Keep going to the right and there's a, yes, perfect. That's what we want. So for those of you who've just joined us, we're doing a practice vote. Please contribute. For those of you who've joined us in the room, we're about to do that. So get your phone out, get your laptop out, and contribute. For those of you who've not voted online, please do so. This is a practice motion, answering the question, which was totally reasonable in the room, of what's the motion? It's a practice. It is. And should it be a real motion, we would go, would anybody like to comment on why they voted negative? Actually, it is. The motion will pass, based on these results. We're a very positive group. All right. Let's go with that. So that's how this will go. Shelley, if you'll stop sharing now, I will share again. Righto. So that's how we're going to make decisions today. We're going to go through and discuss things, and as we come to certain decision points, or if we want information, we're going to use Menti. This is going to come up again and again and again. So if you use your laptop, don't navigate away from that screen. And let me fix the display settings. And if you use your phone, again, don't navigate away from that. We're going to keep coming back to it. But first off, so today's the work group meeting day as part of the Tasman Symposium. This is the patient summary bit. It's between lunch and afternoon tea. After this is EREC. So we're going to move through. We have about an hour and 15 minutes less now. But let's move through. So today's agenda. Today's agenda is usual business that we do in every fortnightly call, which is approval of minutes, any updates and news. Then we're going to the use case design decisions. That's what we forecast. I think last week or the week before would be the key for today, is starting to work through those in a more specific fashion for the IG. Now that we have approved the approach to documenting some use case examples in the patient summary IG. This is what we're going to be looking through prior to going into the Connect-a-thon work tomorrow. We're going to talk then about what's next, which is talking through the Connect-a-thon and also the next few meetings and what we're going to talk through for patient summary purposes. So, usual business. We've got approval of minutes. I'm going to bring those up now. These were put out for review last week sometime. As we go through those, you can see we've got, the agenda here. We've got the attendees. There's the YouTube link, the slides. We've got the summary points of what was discussed, any of the decisions made, any of the mentees that we undertook. All of those are in the minutes. All feedback has been incorporated at this point. But prior to making a motion for approval, I need to ask, does anybody need more time, whether you're in person or online, before we motion to approve these minutes? All right, I'm not seeing any. Does anyone want to motion for approval of the minutes of our last call? Not even the minute
I'll
taker.
motion to approve.
Andrew. Okay, we've got a motioner, Andrew, and I feel like an auctioneer at this point. Would anybody like to second that? Landon put his hand up first, so we've got we've got a motioner from Andrew, a seconder from Landon. Are there any comments or questions before we go to the Menti vote? No. Shelley, do you want to share the Menti again, please? And move on to the vote. Okay, so this is a vote for approval.
Can't hear you, Danielle. Is it just me?
No, it's not just you. The microphone cut out. But people are voting nonetheless, which is great. So affirmative if you approve the minutes, negative if you don't approve the minutes, you think there's something that needs to change, and abstain if you didn't attend. Basically, you weren't at the minutes at that meeting. Right. So we're going to count that down in 5, 4, 3, 2, 1. All right, we'll take that as the numbers for the minutes. So that is 11 affirmative, 0 negative, 8 abstain. The motion is carried. Those minutes are passed. Thank you. Shelley, you can stop sharing. I will go back to sharing the slides. Okay. So we've approved those minutes. Actions, there have been none out of the recent minutes. Let's go through updates. So the patient summary snapshot for the Connectathon was published last Monday. So that's out, that's available, that's going to be loaded in the Spark server. And I just clicked on something accidentally. Come back to the slides. Okay. Right. So that's out there and available. If anyone has any questions, pop your hand up now. We'll talk through it, especially if you found any issues. Okay, AU core dosage. So AU core dosage happened not like just an hour ago. That's gone through. That's been voted on in terms of the AU core proposal. That has no impact on us. And that has no impact on the AU patient summary project because what was put forward in core is to propose that a subset of rules from patient summary are what is viable for core. So AU core medication statement and medication request will now have must support on the text element and nothing more. Whereas in patient summary, in both the AU patient summary, medication statement and request, we already have must support on text, and there's also must support on timing, and there's also some other rules. So the decision made in core does not change what happens in patient summary, which makes sense because that's the point of core, is to be across multiple different scenarios. The PSS, so the project scope statement for patient summary was submitted to the firework group this morning, which was seeking approval to progress with the R1 scope for the patient summary FHIR IG project. The scope that was put forwards to the firework group was what we had agreed in the December scoping workshops, and that was accepted by the firework group. So we now have approval for that. The next gate for that is for it to be submitted to the board for approval, and I will keep this group up to date as to whether or not the board endorses that approval or if they have any objections or amendments needed for that. Okay, I wanted to just call out a couple of things before we move into the meat of today's discussion. So there's a couple of Zulip polls out here. So we've got 2 new ones. There's been a bunch of content that's come out really quite recently and a whole bunch of feedback that's fed into that, like around dosage. But there's 2 polls out. Now, I'm raising these simply for awareness, and as an implementer, you're probably well placed to respond to this, even though neither of these are in the scope of patient summary. So this is healthcare service, this top one, where the agency has indicated that they, as part of their Health Connect program, would like to establish a core profile in AU Core R2 for healthcare service. And they're seeking some information on who is implementing and how they're implementing healthcare service through Zulip. And that's that first channel there that is taking forever to load, which doesn't directly impact patient summary, but I'm raising it to the people on the line because I think it is relevant to everyone. And it would be worth responding to the really short set of questions that are multiple choice to feed into what the agency is proposing around healthcare service. The next one is about coverage, where the FHIR work group is seeking some more information about coverage, which is also really probably going to feed into e-requesting and likely either R3 core or R4 core. I'm not seeing this as particularly imminent for patient summary, but regardless, it is relevant to the implementers on the line who are implementing coverage information, which is to say information about whether or not a patient is covered for a particular service by Medicare or DVA or private health insurance or is self-paying or some other funding arrangement, to provide some input into this as the FHIR work group and the AUE requesting TDG work through it. So this is more of an FYI to this call that these things are being worked through and it is worth contributing to this. Also, because it's really short multiple choice. Any questions about these ones before I move on? All right, I'm seeing nothing online or in person, so I'm just going to move on from this. If you do have any questions, you can actually post them in the chat.fhir.org post. Okay, I want to draw everyone's attention back to this. There's a Spark DOI out. The expression of interest is a super early expression of interest to understand who wants to test things. There are obviously connectathons that happen 3 times a year, and they're incredibly important events, and we come to those. But last year we ran a couple of one-day events in terms of Spark testing that were incredibly valuable, that put a small number of vendors in the room, and these were heavy vendor-focused content. That also had the Sparked and other kind of senior leads from the projects in the room to bring people up to speed and connect things. And we got a lot of feedback that those events were worth it, were incredibly valuable, and people would like to do that again. And so we're coming out with an EOI here to understand, now past just AU core, who's interested in testing one or a combination of core patient summary e-requesting and also things like smart forms, smart app launch for your use case, bringing those together and understanding where and when you're interested in testing this content. This EOI to get a very kind of early estimate is really only open this week. So we're going to close this EOI Friday. And this is going to help us work through, do we even hold this year or not? To be honest, these kind of activities are totally driven from the community as to whether or not there's an interest or support there for having opportunities to test things and focused events outside of the connectathons. And that's what we're trying to understand. What would you want to do? When would you want to do it? And where would you want to do it? So please respond to that EOI to provide us that information if you have any interest in testing. Are there any questions around this one? I'm not seeing any in the room, which isn't a surprise because this is our 3rd meeting together. And this is my 3rd time asking you, do you have any questions about this? So that's fine. People on the line, nope. All right. If you want to reach out, you can either email sparked@csiro.au or you can email me. And if you've got any questions about what is this thing, is it even worth it? Why would I do it? Please feel free to reach out and we can talk to you about that and whether or not that's something that might work for you. So let's get on to the focus steps on the use cases in the FHIR IG. At this point, Shelley, it's probably going to be easier for you to be sharing, so you can actually just move through it instead of telling me to keep moving through the slide pack. What do you reckon?
Yeah, no problem. I can do that.
Right, I'll give it over to you.
Lovely. Just checking everyone can see my screen.
Yep.
Yep, good-o. Okay, so for those of you that don't know me, my name's Shelley Bean. I'm a senior business analyst at CSIRO. Welcome. So today we're going to go and start making some decisions around which steps in our consumer journeys that we want to focus on in the AU Patient Summary FHIR Implementation Guide use cases. So what are we going to do today? So it's time to pick which steps we're going to work on as the use case in the AU Patient Summary FHIR IG. So while we've got multiple steps in our consumer journeys, what we want to do is we've got to be a bit strategic. You know, realistically, we can only focus on one or two key steps, both in terms of the work that we can support and what the technical design group can engage with effectively. So the steps that we choose are the ones that are going to shape the use cases that we demonstrate and the examples that we include in the IG. So some of those elements, such as security and privacy, they're fundamental to all exchanges, and they're assumed to be addressed as part of system implementation. So we're not making decisions about those. We're not making decisions about whether consent exists. That's always a given. This IG, it's not about defining consent, security, or access control mechanisms. Instead, what we want to focus on is the patient summary specific aspects of interoperability. So to make those decisions, we're going to go through a live voting process using Menti, like you've just seen. And this will allow us to gauge consensus and just to make sure that we're prioritising the most impactful and practical steps. And then hopefully by the end of this session, we'll have some clarity on which steps we're going to focus on, making sure that our work's aligning with both implementation feasibility and the broader TDG discussions. So before we get into today's discussion, I just want to set the tone for how we're approaching this session. So our focus is on the people that are implementing patient summaries right now and in the very short term. So we're here to provide practical real-world guidance to help make that implementation smoother and more effective. We want to focus on the common 80% for the first set, establishing the common basics for implementers. And that means that we're prioritising the common over the complex. So we're not here to explore rare edge cases that impact fewer than 5% of our implementers. What we're doing is we're zeroing in on the most widely applicable scenarios. So the things that are going to give us the biggest impact for effort. And so to do that, we need to keep things simple and actionable. So if something feels overly complex or theoretical, we should stop and ask ourselves, you know, does this help people implement today? And if it doesn't, then we should adjust our focus. And lastly, I just want to point out that this is a conversation. So if something we're discussing doesn't seem practical or helpful for implementation, let's talk about it. Your input's going to help us make sure that we're making the right decisions to support real-world adoption. So with that, we'll get into it. And if you're not familiar with our consumer journeys, here they are again, just as a quick reminder. We've got our interstate GP visit, we've got our emergency hospital attendance, and our referral to specialist and allied health. If you'd like more details on these consumer journeys, you can find them on the Sparked website, and I've also put a link to them in the chat there for easy access. But for today, we're just going to keep things moving because we're in a working group meeting and we've only got a limited amount of time. So we'll keep moving forward. So we've been talking about these key characteristics throughout all of our discussions. So these are our big ticket decisions, the ones that are going to fundamentally shape the AU patient summary use cases. You know, these are the factors that really differentiate the use cases and products, not just the things that are always true. So the first one we're going to have a look at is the author. So the author determines who's responsible for populating the patient summary. So that could be a patient, it could be a provider, and that could be, the provider could be a direct author, or it could be through curation from one source, or it could be multiple sources. That could be a device, and that device could be machine generating from a single source, or it could be aggregating data across systems. So that's one of the things we're going to have a look at. The next one is mediation. So that's defining how the access to the patient summary is going to be facilitated. So that can be made up of the human actor, which is what we've got predefined by the consumer journeys. And it also contains the mechanism. So for example, are we going to use a link or a QR code? And those things, we haven't defined those for the consumer journeys yet. So we're going to start taking a look at some of those today. We've also got provisions, so that determines how the patient summary is going to be made available to the recipient. So we want to make sure that it can be accessed in a usable and a meaningful way. We're also going to have a look at currency and specificity. So that establishes whether the patient summary, should it always reflect the most recent data across the ecosystem, or should it just be within a single system? Do we want specific historical versions that need to be retained and referenced? We're also going to look at attestation and signatures. So these define the level of verification and accountability that we need for our patient summary. So making sure that it's authentic and it's reliable in different clinical contexts. And then finally, we've got other access. So I guess we need to consider whether we need access beyond the primary human actor that's identified in the consumer journey. And should that be explicitly defined, or is this outside of the scope of our discussion today? So coming up in a little bit, I'm going to give you a Menti to ask you which of these characteristics that you'd like the use cases in the FHIR IG to demonstrate in AU Patient Summary R1. And what we're going to do when we ask this, we're going to ask you to focus on what you're implementing right now, what you're going to be implementing soon, and what will provide the greatest value to implementers in the short to the medium term. Any questions so far? Was that you, Theo, or? Nope. Okay. Okay, once we get that information, the next thing we're going to do is we're going to map those to our consumer journeys. So we're going to go through as a group and we're going to pick which steps we're going to focus on, and we're going to elaborate on those. So this is just a little bit of an example of what we're about to take you through. So we're going to have a look at each of the relevant steps in each consumer journey. We'll have a look at where we've already identified which decisions have already been made. And then we'll look at the decisions that we still need to make. And we'll make a choice, do we want this, or do we want this, or do we want that? What do we think this really is? And so just to give you a bit of an example, if we have a look at the interstate GP visit at step number 2 here, we've got Jeremy travelling interstate to Queensland for a holiday. Jeremy checks that his patient summary has been updated by his usual GP following a recent admission to hospital prior to travelling. So if we can assume that Jeremy's patient summary has been updated by his usual GP, then we wouldn't expect that this step's going to be patient authored. And again, if we expect that this is provider authored, then we need to make a decision on how this is going to be authored. Is it going to be direct authored? Is it going to be curated? Those are the things that we can make some decisions on. And then again, if it's Jeremy, the patient, that's checking his own patient summary, we can probably assume that it's mediated by a human actor. But we need to make a decision on how that's going to be mediated. So is it going to be a link? Is it going to be a QR code? Is it going to be through an app? And so on and so forth. So if we have a look at another example, this is our referral to specialist and allied health. So for step 1 of that consumer journey, we've got referral creation, where Dr. Burrows shares care of Joyce, who's pregnant, and she's recently been diagnosed with gestational diabetes. So Dr. Burrows is going to send an electronic referral to both an endocrinologist and a dietitian for further evaluation and support. So from this, we already know that it's provider authored and it's being mediated by a human actor. But what we don't know is, how is that being mediated? Are we going to add a link, or are we going to add it as an attachment? Are we curating the patient summary from a single source system, or are we going to get it across multiple sources? Which patient summary are we going to be providing? Is it going to be the latest patient summary or the most recent patient summary? Or is it going to be a specific patient summary at a point in time? And so these are just some of the questions that we'll be asking you today. Okay, so now it's your turn to weigh in. So we're going to go back into Menti. Sorry, Danielle, did you have something
before we go back?
Add?
Yeah, let's go back.
Yep.
Can we, and that was brilliant. Love it. Thank you very much, Shelley. Could we go back maybe 2 slides, maybe 5?
You tell me when to stop. Say
I
stop.
will. Go back to author.
There we go.
Yes, perfect. So before we go, what do we want? I think the question needs to be to this group is that the things that Shelley has put together, and thank you very much, Shelley. That was a incredibly, really well summarized and articulated kind of set of concepts. That this is what we have seen both from the clinical focus group, who's talked about what they think is happening, and also through the fortnightly calls and the workshops we've had to this point around what people have talked about as the concepts. And I want to validate that here now. I want to double check. Out of this, in terms of authoring, we've heard patient, provider, device, and underneath provider, we've heard these words like whether or not people are actually direct authoring it. We've heard people saying that actually it's being pre-populated, but then they're actually like looking at it, making some decisions, and then saving it. We've heard also that in certain cases that it would be, although there's a word device here, but that's that latest, like it's actually trawling across, whether it's HIE or something else, that's actually pulling across from multiple things to work out what is the latest patient information. And so I'd like to ask now, is this resonating with everyone? This is a summary of what we've heard over the last 3 months. Is this resonating? Is there anything here that is being raised that you're thinking is actually out of not appropriate, that it isn't something that's relevant?
We do have a question in the chat, Danielle, from Sanjeed. Where would my health record fit in all of this?
Go, Sanjeed.
Well, Daniel, this might be a future problem, not a current problem. But again, I know you already talked about the HIE. I know my health record, I think ADHA is also looking at patient summaries. Where would all of that fit into this? Probably not a question that can be answered now, but still.
Well, I think from a My Health Record perspective, and we don't have the My Health Record solution architect in this room. I mean, we have Stephen Chu here, but I'm aware that Ricardo isn't able to join us in this particular Connectathon or this meeting today, who is actually working through what it would mean for the My Health Record to provide that perspective. So I would imagine that if what is being delivered is a automatically generated aggregation across the sources of information the My Health Record is aware of, that is device authored. If there is no mediation from a provider viewing it and therefore a human actually confirming or declining things or adding things in, that is device authored. And we may derive a sense of confidence from the fact that the device is the My Health Record, but it is still a device authored set of content. That's my perspective. Andrew?
Thanks, Danielle. I would say for these author decisions, from an implementer perspective, that the single source device definitely aligns with what we are currently looking at implementing in terms of being able to provide a summary based on the information that we have about a given patient at that point in time. So being able to just look across our record to say these are the current, this is the current summary of this patient authored by the system without having to require an explicit intervention by an author. So they've already done all that work to document all of those different things such as problems, allergies, medications as part of their normal clinical documentation. So we're able to just say, this has already been well attested, well formed. This is what the patient currently has, and surface that as an initial starting point.
Sorry, Danielle, I don't know if you've seen Marika's got her hand up as well.
We'll go into the room to Heath first and then go Marika.
I think it just leads on from Andrew as well. I'm worried about that aggregate across systems because I understand the principle of aggregating data, but there's still only one system or device that is doing the aggregation and effectively authoring the document. So even the term single source, it's not about the source, it's actually the thing that's actually composing it from multiple sources. So it's a single composer more so than a source? Do we really need to know? Because I guess there's other ways to indicate the sources of the various parts.
So in response to that, we're going to note that. That'll go into the minutes. Brett's got his hand up. We'll go to Marika. Then we'll go to Brett. We're not, let's be really clear here. We're reflecting what we've heard, right? That's what this is. This is a summary of what has been heard over the last 3 to 4 months of people talking about things that might happen and that are relevant. Not that we're saying that has to be done, but that's what we're putting up as potentials that people are talking about. And so I think, and I'm still not hearing that that's not a no-go from different people, that that's still a thing that might happen. So let's keep talking about it, but also understand within the context, there's not a decision or a motion here to go, this is the official agreement of what authors can be. This is just a reflection of summary points. And are we missing anything? Is there anything in here that you're going, that's clearly not related to summaries? And both Brett, then Marika, then Angus. Or is it's Marika first, then Brett, then Angus. Sorry, Marika.
Thanks, Danielle. So I would be, apologies if I've missed this in the last couple of months of discussions we've had running meeting conflicts. I'd be interested to hear why you selected device over something like an organization. I guess we're a FHIR facade integrating with BP Premier, and we've got an IPS implementation that is in development at present, and we mapped author to organization that would be the practice that the data lives on. So we would fall under, in terms of what you've listed there, we would fall under single source, under device. But I was just interested in why you picked device as the resource as opposed to organization. Or when I say you, I'm speaking why the community at large, not you specifically.
Yeah, no, I get it. The royal you. Yep. Does anyone want to comment on that, or do we want me to have a go at it? Okay, I'm seeing Heath with his hand up. Heath, have a go.
So the organisation will be the custodian. The device is the actual generator, composer of the document. So that's, I guess, my perspective. Not to say that that's right, but that's my perspective. And again, that goes back to what I was saying before. The sources of the data doesn't matter. There is a single composer of the aggregate of information. And the My Health record is actually a good example of that. It will be aggregating things from multiple systems that are uploading it, but they are the single composer device.
Yep, that makes sense. I'm happy with that explanation. I just wanted to check that hasn't been missed from there.
I think Brett also wants to comment on that perspective.
I was more going to talk to it in general.
Okay, well, maybe I'll comment on the device one, which is true. So what might be picked up from the author is that we don't put organisation, whether that's patient, provider, or device. I think there's an organisation implicit in a lot of these. A device is an entity that sits in front of an organisation. A provider is an entity that sits in front of an organisation. Organisation is allowed, but a lot of what we talk about when we come down to legal and all the rest of it isn't an organisation. We end up talking about what is the thing that is constructing this. And when we talk about My Health record, we tend to talk about it in a device sense rather than the organisation that's operating the My Health record. So that's why I think we've seen device here rather than organisation. It doesn't mean that's how we'll always view it. I think it's a reflection of the conversations we've been having over what we see is constructing the information. Yeah, that's my perspective.
Thanks, Danielle.
Yeah, I was just going to comment on the language here, and it's going back to what Heath was kind of saying about words like source and composer and how we talk about it, because like when every GP system aggregates data from other places, all reports that come back and observations are imported, they're actually coming, the source is not the GP system. Okay, so I think it's more complicated if you really want to know provenance of information, right? So I think as a device though, it's you can have a single composer, that's essentially, it's coming from a system. Aggregate's an interesting word because you can federate across multiple source, systems. You can pull data together and represent it as your own, so I think that some of that language is going to be difficult to explain unless we really tease it out. Yeah, so in some ways it kind of points at the more difficult problem of knowing where all the information contained in the summary came from, and who is responsible, and being able to assert, you understand that in different ways. And having said that, in some ways, like if I know it's coming from a composing system, and that system is prepared to provide it to me, maybe I don't care, right? It's just that I know which system to ask the question to if I need to know the detail. And I think we need to kind of explore how much information people need about the source information. That's a different problem. So in some ways, that aggregation and curation across multiple systems, I don't think is that relevant to the discussion, because effectively it's coming from a system. It's a device is going to be sending you this, or a provider is going to curate and attest to it, right? So I don't, in some ways, unless I'm going to break it down into where every single element came from, like every single resource came from, it's more complicated than, I don't know, you can't do it at the top level.
I was first going to comment on the organisation device thing, but I agree with everything that was said in Heath. And I guess I'd say a device always has an organisation behind it. The other one I'd bring up, which Danielle will know well from my health record days, is multiple authors. We had the problem with my health record and pathology reports, and not saying this is a pathology report, where pathology reports were sort of deemed, one report was authored by multiple people because the report contained like chemistry and hematology at once, and therefore did not have a single author. And I know we always, from an industry point of view, thought our reports weren't authored by people but by a device, but you couldn't use a device in the My Health Record, so it's good to see device here. So I guess that just leaves the concept of multiple authors. I'm just putting it out there. Is that a thing?
And for the record, Heath just said completely agree. I will also echo that. Now, let's bring this back to the context of this one. And thank God, what we're not trying to do is arrive on a correct answer, because clearly if we were, this would take some years to do so. What we're trying to do is put up, are these the kind of things we make decisions about? And even from the discussion in the room, what I can hear is these are the kinds of things that happen, basically. I've not heard any new things that aren't on the bullet point list that happen. So I think we can probably move on. So, Shelley, if you can go to the next slide, and I'm going to keep doing this, and we might not even get to the mentees. Shelley's got a smashing set of mentees. And if we don't get to them in this meeting, it'll be in 2 weeks' time, just sort of forecasting you'll want to join us on a Friday. But what we want to talk through are these actually the questions that we want to start asking about patient summary? So we talked about authorship. So the next one is mediation. Now, we've got a great set of consumer journeys that have come through from the clinical focus group, which is a subgroup of the clinical design group from Sparked, which is looking at mediation. Mediation in terms of a human actor, as in who is doing this, which from the consumer journey perspective is conceptualized as either the patient actor or the provider actor. That's all we've got. And then we've got a mechanism, as in how are they mediating access to their information? And so here, in terms of mediation, we've got human actor, patient, provider. We've got mechanism. Mechanisms are a set of potential options, whether that's an embedded link, whether that's a QR code, whether that's a, I don't think we have the full list there necessarily. No, but there's more in the Menti. So I guess maybe the question here is this resonating with people that mediation is going to happen through a person and a mechanism? And we've got Heath again. Where can I get him a microphone? Have we lost the other one? Okay.
I'm struggling with the word facilitated. Do we, with the mediation, are we talking about initiated? Are we requesting it?
I believe the conception is from a consumer journey perspective or a clinical perspective, mediation is viewed as which human and mechanism is enabling them to access a patient summary. So I don't know if facilitation is the right word, but if we look at the 3 use cases that are coming into R1, being the emergency hospital admittance, which is clinician mediated. If we look at the interstate GP visit, which is patient mediated. And if we look at the referral to specialist and allied health, which is also clinician mediated according to the consumer journey that has been defined for us.
So it's about the initiation of retrieving it, not about creating it. Because the patient.
No, not necessarily. It's about,
Go to the patient
I think it's
example.
about access, not generation. I don't believe that our consumer journeys have been set up to predefine generation.
Yeah.
I believe mediation is access decided in our consumer journeys.
Because some of the, sorry, Brett, some of the consumer journeys are around the, like the patient has asked for a patient summary to be created and then they start carrying it. So that's what I'm struggling with here as we talk about that being the patient mediated one. Are we talking about the fact that they're carrying it or the fact that they asked for it in the first place? And which is really around the generation side rather than the retrieving.
I believe the mediation is access, not generation. It's I guess view to, yes, my expectation of this mediation is view, not generation, which I agree is a important aspect.
So are we missing one?
Maybe we're gonna get through that, and we're also going to ask the question of, are we missing one? Yeah.
Thank you.
I just have a question about whether we're like, are we defining policy and access like methodology?
I have a question back to you. What do you mean by policy?
Well, because all this access implies there are certain access rights or access.
Oh, that's
Mechanism,
easily
like-
answered. So, in a facetious way, where Shelley clearly called out that the common things around patient security, privacy, consent are assumed to be true. We're only talking about the patient summary specific interesting bits, not the will anyone have access to a patient record? No, outside of the scope of this conversation.
So are we just like, what is this then? Mechanisms?
This mechanism is for patient summary specifically versus any other kind of thing. Is there a specific mechanism that makes it unique to any other kind of thing, which is absent any particular requirements of some sort of national consent framework or security or privacy in order to make it happen? And it's a question. Is there?
But I think it's all context specific. How you access it may be context specific. I don't mind having mechanisms that are known, like we.
And at this
Just
point,
these
I probably
calls,
want to go,
things
can
like
I just check with you? Is this a question we should even be asking? And I'll come to you in a second, Andrew, is let's just recheck this. This isn't a right or wrong answer. This is as we go through examples and working through what's meaningful for us to discuss, is that meaningful for us to discuss? If it's not, we don't. If it is, yes. Not, is there a right or wrong answer, right? Like, that's not what we're trying to get to.
Because I think there's definitely value in this is how we access the data, and if links is
And that's
part of
it.
how, that's
Yeah,
fine.
yeah.
But
If
I'm not
that's
going to say
a patient
you need to do that at any point.
and this
in
is
this
how,
episode.
that's what these two are. That's all it is. It's not that
I consider those completely
complex.
separate from the patient summary IG, because I'd like.
Hang on, we'll
Yeah.
come to Steve in a second. So we're going to go to Andrew, then we're going to go Heath, then we're going to go to Stephen. And I did honestly expect, oh, is there a Kathleen? Okay, so we're going to go Andrew, Kathleen, Heath, Stephen. Okay, Andrew, you're up.
Yeah, I think I kind of agree with Brett of if we have that base level of the policy around, access to that patient, and those are all base assumptions that are defined by a given organization or implementer, that the mediation for the initial scope shouldn't be scrutinized too much. I think a lot of, from again personal implementer experience, we're more focusing on just getting a patient summary available to be retrieved or queried, and there's more things that should be focused on prior to the mediation mechanisms, as long as that initial policy is, like you mentioned, just a base assumption.
Okay, thanks, Andrew. Kathleen?
Yeah, I'm just looking at this, and I think part of this is how it's worded. I think the mechanism is fine. I think the how to access is fine. It's the when and why that is probably the issue here. And because it said defines how access to the patient summary is facilitated, I think that line in itself should be about the action to access it, not the if you're meant to access it.
Yeah, that makes sense. Yeah, I think that's good. Shelley, let's take a note to update that. I think that's right.
I still think initiated might be a way of just better articulating that the mediation is actually the initiation of accessing it. My comment, the way I was struggling on the previous slide a little bit, I was getting hung up on the detail, and then realized at the end of that conversation that it wasn't They were just examples of a device and how they were sourcing information. So there wasn't so much about aggregating it and stuff. And I see the same thing here. This is actually an abstraction. So the second level of dot points is there is an actor, there is a mechanism associated with the mediation. The linking QR codes are just examples. I think. Am I interpreting that right, Shelley? Like,
Yep,
the
that's
pennies
correct.
dropped for me
Yep.
sorry, now.
Yep.
But that hopefully that helps the room as well. So we're not saying it will be a link or a QR code. That's not the solution, but there is some mechanism. That's what AU Core will do.
There's also a question in the chat, Danielle from Sanjeed, about where my health record, where would breaking glass emergency access request fit here? Or is that a use case that we're not considering right now?
Oh, well, we'll go Stephen, and then we might contemplate that, and then we'll go Tor.
All right. I'm responding to your questions, Daniel, earlier about these FHIR talking points. So in my view, there are two aspects of considerations. One is the content, which is the static part, and the other one is the dynamic, which is the behavioral part. Now, if we are talking about an implementation guide, we can't separate the two. We will have to have the content and also have to model the behavior as well. All right. So that's the reason why I'm responding to Brett to say that these are different. I don't think that they are different. They are different aspects, but they need to be considered as well. Now, then there's the second is the language. Is facilitating or mediation, what are the better languages? So that's come back to what sort of behavior we are actually supporting. So the kind of behavior that we're supporting would depends on the use cases that we would need to consider. Where you might have, say, for example, a patient may just sort of push at the push of a button and say that, look, the system out there that I have access to, for example, my health record, I want a patient summary to be generated within this period of days. All right. So that's sort of kind of use cases would involve a person and involve the device and involve the organization. So again, we can't have a very clear-cut answer as well. It has to be definitely the device, or it has to be definitely an organization. And when then to complicate the conversation a bit more, you then look at sort of who is the author or who is the generator and who is the authenticator. So those are the questions that we need to unpack further down the track as we advance into the implementation guide design. That's my 2 cents worth.
All right. Thanks, Stephen.
Yeah,
Jill?
I don't have a question. I just wanted to, I guess, give a bit of context around when we were working on the consumer journeys from the clinical focus group, that we had a similar conversation around some of the policy enablers that are required to support this work, and how when we were talking about, who has the right to access and how they access it and stuff like that, we can say from the clinical perspective that we know that these things need to be enabled, but how they're done technically and how they're enabled from a policy perspective are things that sit outside of the scope of the clinical focus group. So I guess I just wanted to, get to Brett's point, call out that when we were talking through the clinical workflows and what it means, that we did have similar questions around where we can when we need to draw the line between defining the clinical journey and the clinical workflow, what the technical thing is that you guys are solving, and then also those policy enablers that are required for patient summary as well. So I just wanted to give that context for the discussion.
Yep, that makes sense. So coming back to the chat then, where Sanjeed was asking, and what was, hang on, where would my health record fit in all of this?
Oh, next one, sorry. So it's the breaking glass access or emergency request.
And I suspect here that we actually need to direct that to a My Health Record rep, not this group, to answer. I know there will be some during this breakout, but certainly I don't think we could. I mean, Brett, I know I can see you hand waving.
No, I think it's just another case of when am I allowed to access the information? So that's a policy problem with emergency break the glasses policy problem. Where
Yeah.
the data is, I've got to locate it, and then I need an identity and authorization to access it, right?
Right, question though. Mechanism will be supported by us, right? What will be the mechanism?
Well, it could be anything. That's the thing. Like we have to, like if you want to have that agreement on how the mechanism works, I think that's something that applies to all via interfaces, not just patient summary, right? So it's you know,
Yeah, discovery with limited information. I think we had that.
Yeah, because you might say the best health summary is in this GP system. I now have emergency access to this GP data directly, right? And that might be a way to do it. That's not my health record, but that's an emergency access case. But that's all policy questions again about who's allowed to do that and what, how you do it. I think in the IG though, like I assume there'll be a call I can make to get that data, right? And that's what I want to define. But whether I can make that call or not, it's a different question. Or find the endpoint where I make the call. Right, and these are all things, but these are not patient summary problems. These are endpoint location problems and access and authority and identity.
All right, so unless people have other questions or comments, I'm going to call this slide magnificent and move on. Because at this point, I know we've had a ton of conversation around it, which has been great and will be in the minutes and the recording of this, but it's still capturing the fact that we have human actors and we have some mechanisms and a whole bunch of policy things around it. So let's move on to the next one. Now, we don't have that much time here, so I don't think we're actually going to get to the mentees today. So I'm going to say to people who care, come join us. You know, in 2 weeks' time on a Friday, we're going to move beyond this. What are these things we're actually arguing around being the big ticket decision to go, what do you want to see? Though that predicates itself on the discussion today, which is crucial, and we're going to keep doing it. But let's move on, Shelley, to the next slide. So we've had authors, and we've not seen anything new, and that doesn't surprise us because Patient Summary as a project has been going now for 4 or 5 months, right? And we've been arguing about clinical workflows and otherwise for 4 or 5 months. And we've seen that. And we've seen mediation. And that's gone through a ridiculous number of peak bodies and so forth arguing about it. So that's fine. Now we're looking at this. This is a bit more tech. So this I'm putting to you folks. This we've not seen a ton of the clinical peak bodies look at. So please focus in on this. We've got here the first bullet point. Yes, okay, we've argued about that infinitum, but let's redo it. The next couple, though, new. So first bullet point, currency. The whole what patient summary are you actually talking about seems to dominate every single conversation we have. It really does. Is it for this workflow? Is it for referral? Is it for something else? Are you talking about most recent? Are you talking about some kind of aggregated current view of a person's entire summary of their record? Or are you saying that I want to actually see the thing that someone authored at some point in time? And so that currency thing for me seems to be incredibly dominating the conversations I'm seeing across both the CDG and everything else. So I guess we want to reflect that here to go, is it really for you as well in terms of implementing in a technical space and how? And then we've got the next few around attestation and signatures, which I must confess here, I come from the agency, formerly NETA, which means I come from a whole, CDG or CDA background, and prior to that, V2, which means I've always expected some sort of medico-legal signatures kind of thing, which seems to have sort of maybe disappeared from a bunch of the conversations. But here, the question in terms of patient summaries, is this coming back? Is that what you actually expect? Do you expect every time you see a patient summary to see something that's signed and attested and who attested it? Now, we've got two hands up already. There's Brett, followed by Michael, and we're over time. Yeah, thank you. So we'll go to Brett.
I don't think these are decisions to be made by the group. I think these are options that need to be explained. So currency and specificity, like I think the answer is yes, I want both things, and it depends who I am and what system I have at different times. So I want to know how I could tell the difference and what would be the mechanism to produce a current summary and a point in time summary or a record of it. Attestation and signatures, I think there are cases where that's appropriate and you do want attested content in some situations. So we should say how people do that. And other access, I think, yeah, for sure. Systems are going to want to access this data for whatever decision support, whatever other mechanisms that need to do things. So it's kind of like, I don't think they're questions as such. It's more just how we're going to cover and define how you would do each of those things.
I'm going to rebut that to say they're questions from the remembering that this isn't spec, this is just use case. We're going, here's an example. And so in our example, we need to define, is it latest or most recent or a specific? And that's relevant to say this example does the following things. So I think it's relevant from use case. I get what you're coming from an ID perspective, and I agree with you on that.
Sure.
But taking it into the whole, if we show a FHIR example, we're showing a FHIR example that does something.
It's the word should, right? Because like it should be this way, right? And I don't think that is like even in the use cases necessarily the decision
You're right.
made, right?
We'll get rid of the word should because that is conformance wordy. And this is an example, not a mandate. It's not conformance requirement. It's simply saying, in this example, is it showing the most recent? Is it showing a specific?
Yeah. And I think that's appropriate because like in some scenarios I go, yes, this is a summary at the point in time. I will send it with the request.
Yeah.
Or I might send a request and say, I'll give you access to whatever's current. Because this is, a care plan referral and I want you to always have access to everything going forwards.
Sure.
So these are just, I guess, for examples, I just think name what we're doing and that's fine.
All right. So in the interest of time, noting again, there'll be a call in a fortnight. We'll vote on these, but before we vote on them, is this making sense to people? Like this, like there's some kind of decision about currency. Is it most recent? Is it some sort of actual specific thing that isn't based on most recent? Do you even need to attest it? Is there something you're looking for in terms of actual signatures, some kind of legal, medico-legal attestation? Is that relevant to your use case? And actually, we've not heard that. And I need to ask this. I've raised it because I come from an agency background, which means this was big, but I've not heard it. So we've got a hand up. And can I get other people, hands up on the line, hands up in person. Do you actually need to attest anything? I'm seeing iffy hands in person. Is there any hand? We've got a few online. Okay, so it's relevant. We might have signatures. We might actually go, this is a thing. I've curated it. Let me actually sign my name to it. Yeah. It's not mandatory, but like a whole, it might be a thing. Yeah? Okay. Cool. Put your hand down if you were just about attestation and signatures, but keep it up if you had another thing to say, and I'll come to you. All right, we're about to finish up. in terms of talking about what are the big ticket decisions to make. So first off, I'll go online, and is that you? Hang on, Natasha.
Yeah, hi. Sorry, this is my first event that I've attended, so I'm still trying to get my head around how you work. But I'm a clinician by background, so and I've been looking at your use cases that you're presenting, and a lot of this information is very use case dependent, as you've said, like, how I'm actually wanting to access the information. But as a clinician, as long as you have the currency and the specificity. So, for example, when was the date and the time that the information was populated, and whether or not it had been signed by a clinician, then I can make a clinical judgment as to how relevant that information is. So if I get some information that came from a source system, which is SA Pathology, so I'm from South Australia, right, that has been viewed by a pathologist and that's signed, I'm going to take that as accurate information. If a patient's just put in some information that my last blood glucose level was 7, I may want to have a conversation with the patient to say, is this accurate? So as long as I know where the information's come from, the date and the time it was entered, then I can make a judgment on its relevancy. Is that what we're trying to get to?
Yeah, I definitely think that's part of it. Thanks, Natasha. Yep. Okay, final comments. Is there anyone online or in the room who wants to make a final comment before we wrap up on the big ticket decisions we might make about the different use cases? I see Angus. Okay. Who noted it wasn't clear on the last one, which being the other access. And Brett's popped his hand up.
Hello. I think there's definitely cases for non-human access to systems, right, to get summaries. So there's no...
Oh, are we thinking that the other access is more like HIE, basically? Like it's beyond the provider, patient, and more
I was considering
ecosystem?
secondary use, metrics, other that stuff, right? Because you're going to access all these things.
Like pop health, research, secondary, tertiary. Okay.
Yeah. It's complicated. That's true. Because I mean, that's not because that's not the primary. Like I was reading that like the primary workflows of the cases, right? And they're not the human actors in those cases. They're other things.
Honestly, as a sort of a last word, for the point of getting started with patient summary, I'd ignore it. Right? We're trying to establish some basics. And I'd go, this other access, let's ignore it for now. That might be an R2 business. It might be a later on business. Let's just do the primary stuff. Right. So quick final thing. These big ticket decisions seem to have resonated with everybody. Oh, we had a whole workshop, and this convo was meant to take like 15 minutes, or projected to. I thought it would take longer because we know me, and I'm all like, no, your convo will take longer. And that's going to be next call, where we're going to work through what does it mean to think about these things. Yeah.
I think some of these definitely have content consequences or understanding. So you can talk about currency and specificity in terms of the content that you use in the summary. Signatures and attestation, there'll have to be a representation of that. I think they're pretty more concrete things that we would definitely have in an IG, like ways to do them or ways to understand them, right? But
all right. Can I just wrap up by saying, can I get a show of hands if anyone is concerned, this is a negative, by the way, if anyone objects to us dropping off the other access point for now, we might come back to it, but as we progress, is there anyone either online or in the room? Hang on. You do not have a microphone. You need one if you're going to be talking.
I'm looking at the first question on the Menti, and there's a term characteristics. Are these the characteristics? Because the question says which characteristics are important, and I'd leave that decision to them. If other access doesn't come up, then don't worry about it. Leave it then.
I'm hearing we are good with removing other access for now. Wonderful. By consensus, and let's note in the minutes, other access is out for now.
That's not what I said.
I know it's not what you said. And
I think it's something that needs to be considered. I would keep it personally, because it is important from a.
I'm going to make no, can I ask if anyone will make a motion to remove the other access point?
I'm happy to make a motion, Danielle, Shelley.
So
And
Shelley's
I
made a
also-
motion. Will someone second? Okay, Matt seconded. We're about to go for a Menti. Will anyone have any comments or questions? Great. No, Matt's not Sparked. Sorry. Matt doesn't work for Sparked. Matt works for CSIRO. But I am happy if there are concerns to have a non-CSIRO individual, noting Matt is not a Sparked individual. He works on other CSIRO projects. No? We shall wait. Does anyone else want to second not considering the other bullet point for now? Landon has seconded. We will now go to the Menti. Shelley, I assume you're putting that up. No, that's
Yes.
not necessary. No, not necessarily. It's that third bullet point on the slide about other access.
Hopefully everyone can see that.
Noting if you vote negative, I will ask you to explain your negative. Which is good. Please explain your negative, because only one person has indicated that they would be against it, which has more been they might want to do it in future, which is not a good reason to avoid it for now. Okay, brilliant. We have 4 negatives. Can I ask the people who voted negative to explain why or what parts of the other access are important? Because we really should be folding that into the use case discussion. That's actually really important that we want to capture. Is there anyone who's happy to talk about that? We are, yeah. But 4 people have said negative, which means they want the other stuff. And what is really important, given this limited set of people, is to understand what that other is that people are voting negative so that we can capture it. Mike, where is?
All right, I voted negative because I think it's too early to remove others at this point in time. It needs further discussions. It's a scoping questions that needs to be discussed.
because for me, it's the other way around. It's around a what do we start with? It doesn't prevent other things from coming in. It's a what do we start with? Because the bullet points are what are we going to start with, not a what do we end with.
Yeah, I was negative, and I was similar to Stephen. I was just
Ah.
really struggle with the scope of patient summary to then just narrow it down on the said use case without considering the others is why I was negative.
Well, I mean, those use cases are the set ones. So the steps and the cases we're going to go from are the consumer journeys. There's no movement beyond it. There are those three: the emergency hospital disposition, admittance. Sorry, emergency hospital admittance, the referral to specialist and allied health, the yes, interstate GP. That's the third one. That's it. That's our R1 use cases. Out of those three, we're talking about the big ticket decisions to make out of those three and nothing else.
Given referrals in there, I'm probably happy then.
I mean, referral is in there. And what we were going about is out of the big ticket decisions of author, mediation, those other things, is there some other decision that is the big ticket we're missing? Was the other question we were arguing about. Brett.
I think within those use cases, there are, other than the primary actors, systems and even import and triage and case management and things that sit within those use cases are examples of, but not primary actors doing those things. Particularly like referral, say, if I have a referral into it's a referral to a specialist, there's assumptions there that it's a named specialist. You might be referring to a service, and then you have a case management process that's looking at what is being asked for to decide what to do, right? Which is not the primary actor and not the actual destination. So I think those cases are still open in terms of how you interpret them. So I think other actors.
Okay, I have two comments to that. One, examples, not mandates. We're not actually deciding exactly what happens in none of those. That's not the point. It's just an example.
Sure.
So some of this, I think we're getting caught up in what's the right way to blah.
So
let's not get caught up in it.
Different than attestation. And attestation is not in the case.
I don't know. Let's back up. That's why we had another bullet point, and people are getting really upset about taking the other bullet point out, which is fascinating. And that's fine. And we've had two talks about saying maybe it's too early to take other out of the field. The other two people who voted negative to taking out other, who are they? And non. Okay, that sounded really accusatory. Can I just say, is it about it being too early, or did you have another reason that was different to what we've heard? I guess is what's interesting. Well, okay, so we're not hearing from the others. With 7 affirmative, 4 negative, 4 abstain, the motion passes. Yeah, you don't need to retract, although for the minutes, no, it's fine. I mean, these things will come up. All we're really talking about is driving the initial set of big ticket convos, nothing more about, what's the major things for having some useful examples in the IG. That's all this conversation is about. So can we hang on? Let's mic Angus. We've got gems coming out of Angus, but no mic.
Gems aside. Yeah, no, I mean, I'm here from e-requesting really. And we're kind of looking at this. Is this our clinical information? I don't know. It's too early to know. And that was my concern. And hearing that it is in referral probably ticks the box, because you could kind of call e-requesting a referral. And so I guess I'm just in a limbo of like, is this the answer to extra clinical information in e-requesting or isn't it? And I was just concerned that that point was kind of like taking us out of scope. And maybe we are out of scope. I don't know. It's just too early.
And then over to Steph, and we'll wrap it up at this point because we're well over time. Apologies, people, but it's been great. So go, Steph.
It's a quick question. So if we've to remove other access from that list of big ticket items, are we also going to vote on whether this mechanism of access in the other slide on mediation is going to be removed from scope for now?
No, because what we're going to do is go into a set of mentees that talk about what do people want to see.
Okay.
And the mentees will put up all those things and ask people what people want to see. Again, there's no right or wrong answers. It's an example, not a mandate.
Okay. So just to clarify, we've voted for other access to be out of scope for now.
We've voted
other
to say this nebulous other access for which we have no definition or set
I
of
understand.
answers is not a thing we're going to ask people to mentee on. That's what we've come to the decision on, basically. And no more than that.
I actually agree with Brett's comments earlier about, authorization, authentication, all those concepts being kind of.
Yeah. But I mean,
broad
at the
for-
moment, the next step, which will be in our next meeting, we'll put up a mentee with all the bullet points. We could say represented a thing we understood and go, do we want to see that in an example? That's the next step. The fact that we didn't even know what this other bullet point was, I mean, to me, that's a reason to take it out because we don't know what it is. So what does it even mean if we go, yeah, I want to see it, want to see what? So it doesn't mean it's out because, it's these are just examples and moving on to the next step. All we were talking about is putting up big ticket and what do people recognize as the big ticket decisions for the first step around use cases. That's all this exercise was. And I think we came to a pretty clear consensus actually on where we understood everything and then where we had this whole, there's other stuff. Do we know what the other stuff is? And we were all like, well, no, but we all know there's other stuff, which makes sense, but we don't know what that is yet. And I think that's where we've landed. So, and I think that's fine. I think that's a good position to be in. Are there any other comments before we wrap it up? And again, apologies, we're quite over time. Righto. So I'll see you folks in a fortnight. If you join us, it'll be online. You'll see a mentee with all those options. We just went, I get it. This makes sense. On what do you want to see? Yep. It'll be these set of things, and we'll contrast it against the consumer journeys and we'll go next steps. That's what we're going to do. Remembering these are examples, not mandates. Thanks everybody for your time and contribution. I think this was really, really useful. It was certainly useful for me in understanding some of where everyone's at. Thank you. Thanks, Shelley.
Thanks, everyone.